You're listening to the Better Women series of Matters of Engagement. We're a podcast focused on issues at the intersection of health, healthcare, and society. I'm Jennifer Johannesson.
And I'm Emily Nicholas Angle.
We're excited to bring you episode 4 of this special 5-part series in collaboration with the Canadian Cancer Society and Women's College Hospital. As you'll soon learn, they joined forces to address one of the pressing issues facing both public health and primary care medicine, and that is how to support people in preventing chronic disease through lifestyle behavior change.
Stay with us for a journey through the Better Women Research Project, and we'll learn together about its potential for positive impact on the health of Canadians everywhere.
Well, now the data's been collected, and the team has been working hard to make sense of what they're seeing. In this episode, we're doing a deep dive into the results of the Better Women Study, a research project that tested whether peer health coaching could help women change their preventative health behaviors, like improving rates of cancer screening and making positive changes to diet and exercise.
We interviewed several research team members from Women's College Hospital and the Canadian Cancer Society. And we also got access to the team's first research debrief meeting, where they came together to discuss their findings and make sense of results that didn't go quite as expected.
The Better Women Study built on an earlier program called Better, which provided prevention practitioners to patients to help them establish health-related goals. Better Women extended that support by adding peer health coaches, trained community members who would connect weekly with participants and walk alongside them on their journey as they worked towards those goals.
The research team's hypothesis was that this extra layer of support would boost the program's effectiveness even further. But the results were more complicated than anyone had anticipated. As you'll hear, sometimes the most valuable insights come from studies that don't produce the clear-cut results we're hoping for.
Coming up, we'll review how the study was designed, talk about what they found, examine some of the challenges they encountered along the way, and explore qualitative findings that tell a different story than numbers alone. So, let's get into it.
The research team set up a randomized control trial, the gold standard for testing whether an intervention actually works. So what exactly were they measuring? Well, here's Dr. Noah Ivers, one of the study's lead researchers.
In this instance, what we did was we measured at baseline when people came into the program a whole host of things around their preventative health status. And then we measured those things again at 3 and 6 months. So these are things like, do they follow appropriate diet? Do they exercise as we hope they would? But also more kind of clinical things like, is their blood pressure okay? Is their cholesterol okay? Is their blood sugar okay? And did they get all the cancer screenings they should?
Natasha Kitha-Legoda, another researcher on the team, provides more detail about what those evidence-based targets looked like.
It was physical activity, diet, smoking, alcohol use, and 3 cancer screening statuses that made up a composite primary outcome. For diet and physical activity particularly, it was based on evidence-based targets for those factors. So we used the Mediterranean diet questionnaire to measure changes in diet, and we used a standard physical activity questionnaire to measure changes in physical activity and whether or not participants met the standard of 150 minutes of exercise per week. And then smoking and alcohol use was based on consumption.
But measuring success is only half the equation. To really know if the program worked, they needed a control group for comparison. Well, Dr. Ivers explains.
But if you ask the question, are they doing better because they were in the program versus not in the program? Well, then what you really need is a control group. You need a bunch of people who very well could have been part of the program, but by the by, just didn't get into it yet. In other words, you need to make sure that not only are they not in the program, but they are entirely comparable to the people that did do the program. Otherwise, it's an unfair comparison. And so what we did was we set up what we call a randomized trial. That is to say, we welcome people who are interested to the program to sign up, and then we randomly assign them to get the program now versus get the program later. And so, because it's random assignment, by definition, the group that got it now is entirely comparable to the group that gets it later. And so when we go and compare after a 6-month period, it's a fair comparison.
So, what did they find? Well, the results were not the clear success story the team had hoped for. The bottom line is that the impact of peer health coaching on the measured health markers was not found to be statistically significant.
Now, we're going to get into what that means and why. Now, just a reminder, this Better Women study was built from the results of the original Better study, which looked at the role of prevention practitioners in primary care. In the team's initial debrief meeting, Dr. Ava Grunfeld and Dr. Aisha Lofters discussed that even though the Better Women research project results were not as hoped, the original Better trial results were reaffirmed.
So the result, the primary outcome is not positive, but I think it's really important to look at the fact that the better intervention was effective because there was an improvement of 37%, 42%. And that's in line with the improvements that we saw in the original Better trial. I think we should really emphasize the fact that the better intervention was as effective as it was in the original trials, but there was no additive benefit for the peer health coaching.
Ava, we hadn't thought about the point you just made, which is even though these two numbers, 39% and 42%, are quite similar, they're also substantially bigger than zero. So I think it does reiterate, as you said, that the better intervention is continuing to show itself to be a useful and effective intervention.
Here's Natasha again, who worked on both the quantitative and qualitative aspects of the study, reflecting on her reaction to the results.
I think what felt a little disappointing was that the quantitative results didn't exactly mirror some of the things that we heard in the qualitative interviews. Like, there were a lot of participants that really expressed their admiration of the program and their peer health coach. And unfortunately, that can't be reflected in a single number. The primary outcome wasn't very reflective of the goals that were actually made in the program, and the things that weren't measured played out in reality.
When research doesn't produce the expected results, well, the natural question is, why? The team identified several factors that may have influenced their findings. The first one is brought up by Dr. Grunfeld.
The question I have is this a power problem? Since we were not able to include, we didn't meet our original target because of excluded cases.
Statistical power refers to the probability that a study will correctly detect a true effect if one exists. Power is influenced by factors like sample size. The bigger the sample, the higher the power.
And here, Dr. Grunfeld is referring to the fact that some participants didn't continue their follow-up within the study. And those are the excluded cases she referred to. And the exclusion of these participants decreased the sample size and so decreased the statistical power. But sample size isn't the only issue. The team discovered that they may have recruited participants who were already doing pretty well with their health.
This is a common challenge in health research related to volunteer bias. Natasha comments on this pattern.
Many participants at baseline were already up to date on their cancer screening. I think we were trying to target people who weren't necessarily up to date.
Kevin Thorpe, the lead statistician, points out how this affected their ability to show improvement.
This is probably a more up-to-date population than you were perhaps intending. And so therefore, there's actually less real room for improvement in this group.
And here are Dr. Lofters and Dr. Ivers reflecting on this challenge.
And we see this often in research. There is volunteer bias here, that we have people who are up to date on screening, they're doing well overall. And often these are the folks who are like, oh, I'll take even more help. So that is one factor, I think, to consider that we do think will be important to highlight in the paper.
This is a very healthy, well-to-do group who, by and large, may not have had that much room for improvement, both in the control group and the group that got the program.
And another issue emerged around the disconnect between what participants actually wanted to work on versus what the researchers were measuring. This highlights one of the fundamental tensions in health research. How do you measure success in a way that's both scientifically rigorous and meaningful to participants? Here's Dr. Lofters.
When people set goals, it's very much driven by the patient. So we've actually looked at each individual goal, and a lot of the goals were things like, I'm going to stop eating after 8 p.m., or I'm going to drink more water. And they are things that do not necessarily directly translate to the items in our outcome.
Arani Senthil-Morgan, a research coordinator who collected much of the data and worked on the qualitative analysis, elaborates on this mismatch.
Sometimes the goals didn't reflect like the primary outcome measures. Like, for example, someone might have wanted their goal to be more hydrated, to drink 8 glasses of water a day, something like that. That doesn't necessarily translate into what we were looking for, but that was something that was obviously important, for example, to a participant. And sometimes, there were goals that were more centered around like self-care, journaling and that every night or something like that.
Arani reflects on how the coaching approach might work on deeper levels that weren't captured in the short-term measurements.
Let's say like a participant enters peer health coaching a little ambivalent about their health goals, a little ambivalent about making changes. Peer health coaching might then work on that ambivalence piece, which is what motivational interviewing does. And so it might help them kind of increase their willingness or increase their readiness, but it might not necessarily in that time frame that we study translate into, behavioral change, but there is that motivational change that occurs.
Like so many research projects launched in recent years, Better Women was significantly impacted by the COVID-19 pandemic. The program had to pivot from in-person delivery to virtual, a change that may have impacted its effectiveness. Shabina Amlani is a senior prevention specialist at the Canadian Cancer Society, and she raises this important question.
If the program had been delivered the way it was meant to, which was in person, rather than pivoting to the virtual, would we have possibly seen better outcomes?
Kevin Thorpe, the statistician, reflects on how this shift might have mattered.
It makes sense in my head that in-person would have had a stronger effect. Maybe I'm being optimistic, which is rare for a statistician, but if the intent of the support person is more relationship development in order to help them achieve their goals, I can certainly see how the relationship that is intended to develop to work through that might work better in person than it does online. We don't have any evidence of it. It's purely hypothetical and anecdotal, but it is certainly, I think, a worthwhile thing to indicate it's a limitation.
The team also discovered that prevention practitioners actually went above and beyond what the researchers had expected. And this created challenges for measuring how well the intervention worked. Dr. Ivers explains.
One of the things that we found out is that the nurses in each of these clinics, we call them prevention practitioners. They're to remind the listeners, they're meant to meet people and set things up so that they can then hand it over to these coaches if they're in the program. But what we found out is that these nurses in these clinics that were acting as prevention practitioners, they were really committed to their role. And frequently they were meeting with folks 2, 3, or more times. which we never stopped, but we never expected.
Dr. Lofters also confirms this was a consistent pattern across the study. And just a heads up, she refers to prevention practitioners here as PPs.
There were actually quite a few follow-up visits that happened with prevention practitioners. So I think we envisioned in our minds, people are having one visit with a PP, and then they're either being matched with a behavioral health coach or not. But in actuality, there were quite a few PP follow-up visits that happened that also, I think, will be addressed in the Fidelity paper, but could play a role here.
So, how do we make sense of results like these? How to communicate findings that don't fit neatly into success or failure categories. Susan Flynn, a director of cancer prevention programs at the Canadian Cancer Society, offers her perspective.
For various reasons, the findings weren't scientifically significant, but that doesn't mean that there wasn't a lot of value in the work. We do know that we've got a lot of very positive feedback about the peer health coaches, the positive impact this had on them in terms of supporting others and also in terms of their own personal behavior change. Every time we engage in research and we evaluate participants and others involved, we learn something. We learn something valuable that contributes to a body of knowledge that helps support the use of a peer health coach model in other primary care settings.
Still, Susan acknowledges the challenges these results present when it comes to securing funding and looking to broader implementation.
Statistically, when you don't have evidence, it's hard to convince government to fund the project because the briefs that governments provide is this evidence-based or not? And it's a one-pager. It really is just on the broad outcomes. It doesn't focus in on what were the unique learnings and value that can be added in this area moving forward.
Dr. Lofters acknowledges the disappointment, while also emphasizing the value of what they learned.
I know this is not the results that we wanted to see, but this is also why we do the work, why we do the research. And I would remind us all about the qualitative findings that we have that we've been working through. And I think the discussion we've been having, it's not to dismiss these results, like these are real results, but just to bear these results in mind in the context of the program, the goals, etc.
As a qualitative researcher, Arani had ongoing contact with participants throughout data collection, and she wasn't entirely surprised by the disconnect between the qualitative and quantitative findings.
No, I wasn't really surprised because I had that kind of consistent contact with participants while I was collecting. And so I was already hearing bits and pieces about it from there. I think you're going to find different things maybe reflected in qualitative and quantitative. Like a really common thread that you see is patients talking about how, they appreciate the program. It's been a major piece in increasing their self-confidence, but that might not necessarily always translate into drastic health changes. You might have that increase in confidence that occurs, but then does that then mean, their blood pressure is regulated or something like that? Not necessarily.
She reflects on what the qualitative data revealed that the numbers didn't capture.
There's a lot of rich data that comes through qualitative work, and you really get to see participants' real insight into what they're experiencing, and I think you get to understand their lived experience themselves. So yeah, I don't think you get that reflected all the time in quantitative work. On paper, it makes complete sense. It seems like a great model, and I think you also do hear from the participants themselves, they enjoyed it, they appreciated it. So to not have that tangible evidence that says it led to real behavioral changes or real change in their health data, it does feel disappointing.
So, while the quantitative results were disappointing, the qualitative data told a different story. The team conducted extensive interviews with participants, coaches, and clinic staff. And what they heard suggests that meaningful things were happening, even if they weren't captured in the primary outcome measures.
I would highlight that the qualitative interviews, both of the nurses, the prevention practitioners that I spoke about, the coaches, and the participants, were littered with stories of gratitude, success, excitement even about the program. Sometimes stories of frustration, like from the coaches that didn't get perhaps as many participants to work with as they wanted, or in the timing that they wanted, and stuff like that. But mostly stories of, like I said, gratitude and success, narratives about the participant who hit a roadblock, whether it was diet or exercise related or whatever, and the coach feeling really proud about their ability to be there for that person and to help them problem solve through it. These are powerful stories that we heard of, like, I wouldn't say communities that we built, but relationships that we built. I think there's something definitely to be learned from that.
These relationships were important, not just for the participants, but also for the peer health coaches. RNE notes the impact on them as well.
Yeah, I think one thing that was interesting for me is like the real investment put into this by peer health coaches, how they found themselves like mirroring patients' emotions throughout this process. So whether they're experiencing, satisfaction, whether they're experiencing pride, anxiety about not meeting certain goals, like that was something that they also felt within the qualitative work. You could really see that it was indeed like a two-way relationship here. They themselves were kind of experiencing that secondhand feeling of wanting to then work on their own health goals as well.
If you go back to episode 3 in this series, you'll hear some really compelling accounts from the peer health coaches about how much they got out of their roles. So, just because these things aren't measured, it doesn't mean that they aren't real or valid.
Yeah, so while they didn't see the hoped-for results in the short term, the team does have plans to follow participants longer, to see if there are benefits that just take more time to emerge.
Part of the evaluation is to follow through forward to see what happens in terms of healthcare outcomes. So we will translate, and this takes longer to do, we will translate the health card numbers of everybody that was participating, including the control group, bring them over in a secure way that we can monitor, the proportion that ended up going to hospital, the proportion that ended up, with those big definitive outcomes, not the proxy outcomes, but the big long-term ones that can catch the attention of the policymakers. And it can also help us in a way to evaluate healthcare costs.
There's a strong economic rationale for this long-term follow-up.
Yes, it costs some money to get these peer coaches trained and deliver the program, but perhaps these people down the road had less healthcare costs. If you avert one stroke, that more than would pay for the whole program. So that's TBD. It takes longer to do. We have to follow people for longer, and we have to link to in a secure way to the health data sets to do that. That's the kind of data that leads to big programmatic or policy decisions.
Despite the disappointing quantitative results, RNE's sense is that the program has real value. When asked, she said, yeah, it should be scaled up, regardless of these particular results. She explains why, particularly for the population they're serving.
Yeah, I do think it should be scaled up, even if we're not seeing the reflection in the primary outcome measures that we measured. I think the kind of big piece here was accountability, was a major motivating factor for these participants, and played a big role in their kind of enjoyment of it and what they valued of it. Just to consider also the age range of our sample. You call that like the sandwich generation, so to speak. They're caught between caring for their children, they're caught between caring for their aging adults, and it can be really, really hard to be able to balance your personal life and your personal goals with your home life, your professional life, And I think this really kind of helps provide participants with that ability to kind of actually have that time to hone in on that and have someone be there for them. The role that PHCs kind of play here is really leveraging participants' own resources, kind of like taking that strengths-based approach and helping participants recognize that they have their resources within themselves. I think that is something that is like sorely undervalued. I think this program is quite valuable for this.
Okay, so let's wrap up. Let's hear Dr. Ivers' reflection on what the team learned and how these insights might inform future work.
I think, in retrospect, it would have been great to do some co-design work prior to jumping into the trial. Now, the timelines were tough and so on. There were reasons we did this way, but like when your assumptions get shown to be wrong, I think it's a really important moment to like reflect about why you made those assumptions, about what people might want or need or use or not use, and how you can avoid making those assumptions the next time.
The Better Women study reminds us that research rarely unfolds exactly as planned. While the team didn't find the clear evidence of effectiveness they were hoping for, they uncovered valuable insights about participant selection, goal setting, the importance of relationships and health interventions, and a potential gap between what researchers measure and what participants actually value.
And these findings will inform not just future iterations of the Better program, but will contribute to the broader conversation about how we design and evaluate community-based health interventions.
Yeah, sometimes the most important discoveries come from studies that force us to question our assumptions. The team's commitment to understanding not just whether the intervention worked, but why or why not, well, it provides a model for how research can continue to generate knowledge even when results aren't exactly what we hoped for.
And coming up in the 5th and final episode of the Better Women series, we'll be summarizing the entire project, hearing from team members about their key takeaways, touching on some of the complexities of training community volunteers to bolster the healthcare system, and circling back with the peer health coaches for their responses to the research team's early insights.
This series on the Better Women Project was brought to you by Matters of Engagement in collaboration with the Canadian Cancer Society and the Better Women research team at Women's College Hospital.
And special thanks for editorial and administrative support provided by Karen Kuzmich, Christina Macri, and Shabina Amlani at the Canadian Cancer Society, and to Natasha Cthulhu-Goda at Women's College.
And a big thank you to all of our guests on this episode. Dr. Eva Grunfeld, Officer of the Order of Canada, Physician Scientist, and Professor Emeritus at the University of Toronto. Dr. Noah Ivers, Scientist and Family Physician at Women's College Hospital and Canada Research Chair, Tier 2, in Implementation of Evidence-Based Practice. Shabina Amlani, Senior Specialist, Better Women, Canadian Cancer Society. Natasha Cthulhu-Goda, Manager of Implementation Science at Women's College Hospital. Arani Senthil Morgan, Research Coordinator, Better Women, Women's College Hospital. Susan Flynn, a Director of Cancer Prevention at the Canadian Cancer Society. Dr. Aisha Lofters, Scientist, Family Physician, and Chair in Implementation Science at the Peter Gilgan Centre for Women's Cancers, Women's College Hospital, and also co-investigator of Better Women. And Kevin Thorpe, the lead statistician for the Better Women Project. This episode was written and produced by Jennifer Johannesson and Emily Nicholas Engel. For a transcript of this episode and for more information, please visit mattersofengagement.com.